So we're going to move on to our next speaker in this plenary session, Natalie Collins, who is an NH&MRC postdoctoral research fellow with the Department of Mechanical Engineering at the University of Melbourne. Natalie completed her PhD at the University of Queensland, where she conducted an NH&MRC funded randomised clinical trial investigating the 12-month efficacy of foot orthoses and physiotherapy for patellofemoral pain. So we'll be continuing on with that theme. Publication of this study in the British Medical Journal has helped raise the profile of patellofemoral pain in general medical circles worldwide. Natalie has multiple publications and presentations on patellofemoral pain and was involved in the development of a consensus statement regarding current evidence and future research directions for patellofemoral pain at the first International Patellofemoral Pain Syndrome Research Retreat. Her postdoc studies continue to investigate patellofemoral pain conditions, particularly the relationship between patellofemoral pain and patellofemoral joint osteoarthritis. She also holds an appointment as a lecturer within the Department of Physiotherapy at the University of Melbourne, and she maintains a clinical caseload at Olympic Park Sports Medicine Centre in Melbourne. So will you please welcome to the podium Dr. Natalie Collins.
Good afternoon, everybody. I'd like to start by thanking the MPA, breaking the microphone, thanking the MPA for the opportunity to talk to you today about my PhD research, but also putting me on in the same session as Eric, who, as you would have just seen, has contributed a fair amount to what we know about patellofemoral pain, but as an aside to that, is actually also a really nice guy and knows how to carve up a dance floor, so Saturday night, you should be there. As many of you would know, research is very rarely a solo effort, and throughout my career so far, which is relatively short compared to Eric's, I have been very fortunate to work with some incredible academics. In particular, my advisory team being Bill Vicenzino, Kay Crossley and Tom McPoyle, but also the other co-authors on some of the papers that we've published. And I also have to very sincerely thank the NH&MRC for their support for both the project that we conducted, but also for funding both my PhD scholarship and my postdoctoral fellowship. And of course, Facility and the Physiotherapy Research Foundation. So although we have just heard a bit about patellofemoral pain, we will have a little bit of a look at what it is. I'm sure you all are aware of what it is. But it is a lower limb musculoskeletal overuse condition. And although it's often termed a diagnosis of exclusion, so where there's no other pathology that might contribute to pain at the front of the knee, it tends to be the thing that's left over. But what is actually the case is that it has a very characteristic presentation which distinguishes it from those other pathologies. So the primary feature is pain arising from the front of the knee, and this tends to be an insidious onset. It also tends to be aggravated by activities that load the patellofemoral joint, particularly activities that involve knee flexion in weight bearing, such as squatting, going up and down stairs and running. And importantly for us as physios, it's both multifactorial and heterogeneous. And what this means is that there's multiple factors that can contribute to patellofemoral pain, and it's very rarely the same thing in every person. And this is a really important thing to consider when we're selecting our interventions for these people. So if we look at why we need to manage patellofemoral pain effectively, the primary reason is that it tends to have a long-term impact. We know now, we have prospective studies of largely active populations that shows that it's not self-limiting. It hangs around for a long period of time, and it can be up to 16, 20 years in the literature so far. But the other thing is that we now, and Eric alluded to this before, is that we now have preliminary evidence that it may be a precursor to patellofemoral joint osteoarthritis. So this is a degenerative condition that has no cure. And so obviously this can impact substantially on someone's ability to participate in a physically active lifestyle. And this is particularly the case when we think back to those activities that actually aggravate the pain. And of course, this has wider implications for someone's general and mental health. The other thing that we know now is that there appears to be this subgroup of people with patellofemoral pain who have a poor outcome over time. And we've actually looked at 2 prognostic analyses that have sought to identify factors that are present at baseline presentation that might be predictive of whether someone is likely to have a poor outcome over time or not. So the first study that we did looked at 179 people with patellofemoral pain, and this was conducted in an Australian cohort, and we found that a long duration of patellofemoral pain and more severe baseline symptoms were the most consistent predictors of poor outcome over 12 months. Now, when we pooled our data with another cohort from the Netherlands, so we nearly doubled our sample size, again we found that long duration of patellofemoral pain was the most consistent predictor of poor outcome over 12 months. Now, what this tells us is that we may actually be able to enhance outcomes by using effective interventions early on after onset of symptoms in order to minimise the duration and also the severity of their symptoms. Now, if we look traditionally at what physios, and particularly Australian physios, have done for patellofemoral pain, there has been this focus locally at the patellofemoral joint, and rightly so. And I'm sure we're all aware of Jenny McConnell's contribution to the field. But the nice thing about the multimodal program is we know that it works. We've got evidence from randomised controlled trials that shows that it does reduce patellofemoral pain. But we are seeing a lot more emerging evidence that distal factors may also contribute to patellofemoral pain and different alignments that might happen at the patellofemoral joint. And this is where we're more going to focus on today. Now, if we're looking at how the foot, which is all the way down there, can influence what happens at the patella, which is somewhere in the middle, there was a paper published back in 1987 that basically presented a theoretical model as to how the foot might contribute to patellofemoral joint loading and therefore pain. So bearing in mind this is a theoretical model. So basically they proposed that an increase in foot pronation could in turn increase tibial internal rotation via the ankle mortise, which could then increase the internal rotation of the patella via the patellar tendon attachment and contribute to medial loading of the patellofemoral joint. And there are studies that have looked at the distribution of forces on the patellofemoral joint and have shown this. So you can see that is more loaded up on the medial side. If that internal tibial rotation is then coupled with an internal rotation of the femur, because the 2 bones are attached obviously, what can happen here is that you get a relative lateral shift of the patella on the femur, and this can increase the lateral loading of the patellofemoral joint. And again, that same study showed that that's exactly what happened. That's where the stress or the pressure shifts to, that lateral facet. And we do have evidence that foot pronation and patellofemoral pain are related, despite what Eric might have thrown in there before. Just focus on this bit for now. So a recently published prospective study showed that an increase in foot pronation, measured as navicular drop, is a risk factor for the development of patellofemoral pain. We've also got cross-sectional studies that show that people with patellofemoral pain have greater foot pronation than asymptomatic controls. And these are just 2 of them, but there are multiple studies that have shown this. So as physiotherapists, we really do need to look beyond the patellofemoral joint when we're managing patellofemoral pain. And we really should consider interventions that address disorders of foot pronation in appropriate patients. And foot orthoses are one such intervention. Now, this is a definition that we came up with in a publication back in 2007, basically kind of encompassing what foot orthoses might do, because we're really not sure. But basically, they are devices that sit in your shoe, and they're shaped to match the plantar surface of your foot, and used in the prevention and treatment of injury, pain and disability by optimising lower limb function. As a broad categorisation, you've got custom orthoses, which are shaped to match a 3-dimensional representation of the person's foot. And then you have your prefabricated devices, which are generically shaped, but can be either heat moulded or have wedges added to them to customise them a little bit to your patient. But the real question, as I alluded to this morning, is how do foot orthoses actually exert their therapeutic effects? And there's been a lot of research done on this to date, a lot of conjecture in the literature. Is it a biomechanical effect that we're seeing? So are we actually changing the alignment of the foot and lower limb? Is it just that having that device in the shoe actually absorbs some of the shock as you hit the ground? Or is it that having that piece of foam or whatever it is in your shoe actually stimulates your neuromuscular system to work more efficiently? And as I said, despite all this extra research output, unfortunately we still don't know the answer. And I don't know if we ever will. But what we do know is that they work. We know that foot orthoses reduce patellofemoral pain. But what's really important to keep in mind is that all the research so far has focused on or has used prefabricated devices. Nobody has done an RCT to look at whether a custom orthosis has the same effect. So if any of you want to do a PhD, and it's no easy feat by all means, please come and talk to us because we'd really like to know the answer to this. And podiatrists in particular are very interested to show that custom devices do the same thing as prefabs. So this was the main study of my PhD. We conducted a randomised clinical trial that was published back in 2008. And we recruited 179 people with patellofemoral pain, and we randomly allocated them to one of 4 treatment groups. So each of these 4 interventions was delivered by a physio, and some of you will actually be in this room, so thank you very much for your contribution. They saw that physio 6 times over a 6-week period, and then after that they were encouraged to continue with a self-management program. So keep doing your exercises periodically, keep wearing your orthotic. So the people who were allocated to the orthotic group were given Facili orthotics, obviously, because they sponsored us. They were commercially available, generically shaped, and they were given up to 4 pairs so that they would actually fit them to multiple shoes and wear them as much as they could. We did give everybody who was randomised to that group the orthosis. So this was irrespective of their foot type, whether they were pronator, whether they were supinator, whether they were somewhere in the middle, didn't matter, they all got an orthotic. And we also fit them to comfort using the heat moulding and also adding wedges. So comfort was our primary factor when we were fitting the devices. And we thought that not only did the literature show that all the biomechanical angles and things, are they subtalar neutral, are they not, maybe didn't matter so much, but also we wanted them to wear them. If you give someone an uncomfortable orthotic, they're not going to wear it. I think that's, we all see that in our clinics. But what we know more recently, and this is from the research of Kat Mills down at the AIS, is that a less comfortable orthotic can actually increase hip adduction and vastus lateralis activity in people with patellofemoral pain during walking. And these are the 2 things that we're really trying to avoid in these patients. So comfort was a really important factor here. Our flat insert condition was a 3mm piece of EVA. It had the same covering fabric as our orthotics, so it looked legit. And again, people loved them. But basically it had no contouring, no shaping to it. It was just a flat piece of EVA. Those who were assigned to the multimodal physio group received a pretty standard McConnell program, so I'm sure you're all familiar with this. It included some patellar taping, some vasto retraining, focusing on VMO timing, and also we looked at the hip as well, so stretching of hip structures and retraining of hip external rotators. And then those who were assigned to the combined group got the foot orthoses and physiotherapy interventions as I've described. So we had a blinded assessor who took outcome measures at baseline and then again at 6, 12 and 52 weeks. So what I'm going to present to you today is our main primary outcome measure, and this is a measure of global improvement. So this kind of encompasses basically how the patient feels, factoring in their pain levels, what they're able to do, their activity, all sorts of things. And this was measured on a visual analog scale. So 0, as you can see here, means that they're the same as they were at baseline. Anything up this scale here means that they were better, up to 100 being completely recovered. And anything below 0 down to -100 was much worsening. And then on the x-axis here, we've got our 3 follow-up time periods. So if we look first at the comparison between foot orthoses and flat inserts, what we see is a significant effect favouring foot orthoses at 6 weeks. And the numbers that you see in brackets here are 99% confidence intervals. So we're fairly confident that what we saw was a real effect between these 2 devices. And our numbers needed to treat and relative risk reductions also back this up. However, when we looked further down the track, the differences between the 2 at 12 weeks and then at 52 weeks weren't actually significant. We also found that over 12 months, physiotherapy and foot orthoses have similar effects at each follow-up time. And also that combining the 2 interventions made, well, no significant difference compared to using either intervention on their own. Now this next graph here shows a measure of worst pain severity. So again, measured on a visual analogue scale, where 0 represents no pain, 70 to 100 represents the worst pain imaginable. And what you can see is that the overall pattern is the same as what we showed on the global improvement scale. But what this graph shows really nicely is that all 4 of our groups actually improved by a clinically meaningful amount over that 12-month period. So they all improved by more than 20 millimetres on the visual analogue scale, which we know to be the minimal clinically important difference in this patient group. However, using foot orthoses, physiotherapy or a combination of the 2 actually resulted in a quicker reduction in their pain, as you can see in that first 6 weeks, compared to the flat insert group. So if we kind of summarise where we're at now, we have, despite a lack of understanding as to how foot orthoses work, we do have high quality RCT evidence that prefabricated foot orthoses are effective in relieving patellofemoral pain. We found that foot orthoses were more effective than flat inserts in the short term. So what this tells us is that contoured shape of the orthoses does have some therapeutic effect, particularly in that short-term period. We also found that foot orthoses and physiotherapy have similar short and long-term effects. So this, I guess from a clinical standpoint, tells us that orthoses might be an effective alternative for those patients who are less likely to respond to the multimodal program. So these are people who may have an allergy to strapping tape or who are non-compliant with their exercise. And we know from clinical experience that 70% of our patients might actually fit that category. We also found no additional benefit in combining foot orthoses with physiotherapy. So I guess from a clinical standpoint, really we should be using our experience and our reasoning, but also consulting the patient in prescribing that first intervention that we give them. Would they benefit from an orthotic? Would they prefer to go maybe a physiotherapy route to start with? That's all the things that you need to take into consideration. And that brings me to my next point. How do you actually determine which patellofemoral pain patients will actually benefit from foot orthoses? And this is particularly the case when we consider that it is a multifactorial condition. As I'm sure you're all aware, clinical prediction rules are being used much more in the evidence-based and physiotherapy literature, and basically they help us to improve our decision making by giving you a group of factors that you get from your subjective and your physical examinations at baseline that together maximise our accuracy in predicting whether someone will have a positive response or success with a particular intervention. So we actually conducted a post hoc analysis of data from our RCT to look at whether patient characteristics, baseline pain characteristics and the comfort of the device could predict who had a successful outcome with the orthoses at 12 weeks. So we took data just from the foot orthosis group and we had 42 people in this group at 12 weeks. We selected the 12-week time point rather than doing all of them because that would have been a large number of comparisons, which reduces your statistical power. But also we figured that from a patient perspective, 12 weeks would be likely to be a much more meaningful time point to them than the 6-week mark where they've just finished their intervention with the physio, or the 12-month mark where you may not expect them to still be gaining any benefit from it. So we looked at a number of clinical predictors at baseline, and this included age, gender, BMI, measures of foot posture, how long they'd had their pain for, pain severity, their function measured on different questionnaires, and also the overall comfort of the orthosis. And then we measured their outcome at 12 weeks on a Likert scale for global improvement, and we dichotomised this so that we rated those who had said that they were markedly improved at 12 weeks. They were the ones that we categorised as success. So anyone else was classified as a non-success. So basically we took the group that we were very confident had a good outcome or a successful outcome. And these are the 4 factors that we found or that came up in our clinical prediction rule. So as you can see, people over 25, people shorter than 165 centimetres, not sure what that means, people who had a more mobile midfoot. So the midfoot width difference measure basically takes the difference between the width of their midfoot in non-weight bearing compared to weight bearing. So it looks at how much the width of the midfoot changes when you load it on the ground. And so what we found was that the people who had a greater increase in their midfoot width were more likely to have success with the orthotics. And then we also found that those who had a lower severity of pain as rated on a visual analogue scale were also more likely to have success. And so what this slide shows you is that the people who had 3 or more of these factors could improve their success or their chances of success with foot orthoses from 40%, which was our pre-test value, to about 85%. And the positive likelihood ratio here tells us that this represents a moderate shift in probability that is likely to represent a meaningful change or difference. But what we see is that also the people who had 2 factors and even 1 factor also could improve their chances of success above that 40% level. And what we find from the more recent literature is that we're seeing similar things coming out in clinical prediction rules. So this one published by Christian Barton earlier this year, amongst other factors, also showed that a lower level of baseline pain was a predictor. But importantly, this study again by Kat Mills has basically replicated one of the findings that we found. So again, that midfoot width change of greater than 11 millimetres, she found could, or resulted or was associated with about an 80% success rate in people with patellofemoral pain who are managed with orthotics. And this was a really cool finding. You don't expect to find the same numbers in 2 completely different studies. So again, summarising where we're at, in people with patellofemoral pain, a combination of 3 of the following factors being older age, shorter height, more mobile midfoot, and less severity of pain at baseline can increase your probability of success with foot orthoses from 40% to 85%. And it appears that a greater mobility of the midfoot and a lower pain severity at baseline are more consistent predictors of success with orthoses in patellofemoral pain. So I guess taking into account all the evidence that I've presented to you today, it is apparent that the foot is an important contributor to patellofemoral pain. And considering that as physios we are increasingly required or encouraged to utilise evidence when we're making decisions about which treatments to give our patients, but also considering that we do need to approach a multifactorial condition such as patellofemoral pain in a targeted individual manner, we really should be considering foot orthoses for our patients with patellofemoral pain. We have RCT evidence that prefabricated foot orthoses are effective in improving patellofemoral pain, especially if they're comfortable. And this is particularly for those patients who present with factors that suggest that they might be at a greater likelihood of having a successful outcome, this being a greater mobility of their midfoot and also a lower severity of baseline pain. So I guess as musculoskeletal and sports physiotherapists, we can be confident that if we appropriately prescribe foot orthoses in our own clinics, or if we refer our patients to podiatrists for more customised prescription, we can actually enhance our management outcomes for people with patellofemoral pain. Thank you.
Thank you, Natalie, for another outstanding presentation.